many more participants to join. As Bala desires, we are now starting the program. So Arulmozhi sir வந்து நமக்கு புதியவர் அல்ல. பாணிகையில ஏற்கனவே 2-3 நிகழ்வுகளில் வந்து நம்மளோட கலந்துரையாடி மிகவும் ஒரு இன்வால்மெண்டோட நமக்கு நிறைய நிகழ்ச்சிகள்ல அவருடைய அனுபவ பகிர்வை வந்து நமக்கு மிகுந்த செறிவோடு தந்திருக்கிறாரு. ரொம்ப ஒரு அமேசிங் ஹியூமன் பீயிங். As usually I used to mention him, sir. சார் வந்து அவருடைய யூஜி, பிஜி அண்ட் ஸ்பெஷாலிட்டி மூணுமே வந்து பார்த்தீங்கன்னாக்கா மெட்ராஸ் மெடிக்கல் காலேஜில் முடிச்சவங்க. 20+ years of clinical experience கொண்டவங்க. Especially you see the field of pediatric neurology is something very difficult to ascertain and very difficult to distinguish and clinical diagnosis வந்து அரைவ் ஆகிறதுக்கு வந்து ரொம்ப ஒரு சேலஞ்சிங்கான ஒரு field அது. Because as we know, kids couldn't express appropriately, and with all full of his interpretations and intuitions and all his clinical nuances, sir used to apply and arrive diagnosis, and he has shown us many videos in previous programs which we really enjoyed, how he is passionate towards diagnosis of pediatric neurological issues. So we are all happy, sir, to have you here amidst your busy schedule during this hectic pandemic situation. The floor is yours, sir. We are awaiting to enjoy another clinical treat from your end. Over to you, sir.
Have I unmuted? Am I audible, sir?
Yes, sir. Yes, sir. Yes, sir. Now it's audible, sir.
Sir, thanks so much for your warm welcome and nice words. It was always a happy memory to be among you, sir. See, it was really all the time when I would come here, it was really a very warm welcome and a happy time which I spent there, which is unforgettable. It was always a happy memory there from the National Institute of Siddha.
Yes.
But sir, today, sir, we are going to discuss a very important topic on childhood autism. It is actually a very difficult topic because it is a very controversial one. We don't have straightforward diagnosis, straightforward treatment for this. And when I started to prepare, I thought I will share one. There were many couplets from Tirukkural, which caught my idea was that whenever we give a talk or a symposium or any lecture, the great poet, the saint poet, has given us a guidance that how a talk should be. He says that the talk should be as simple as a mathematical equation, straightforward and simple. But for the audience, it is their job to bring out something, a deeper meaning or a complex meaning out of that simple talk. So my challenge is to keep this complex topic as simple as possible. And he has also mentioned that it should be as simple as a mathematical equation. Say, for example, you call it as 2 + 2 = 4 or 1 + 3 = as simple as this mathematical equation. It is our duty to make it as simple as that, whatever complex topic we are going to talk about. So he calls it as en porulaga selacholi pirar vai nun porul kaanbadarivu. So you say a mathematical equation like that, if you check a child, in any child who's having a defective social interaction with an unusual behavior, we think about autism. What defective social interaction is nothing but a language delay and a weird behavior in the form of repetitive, restricted, rigid, and routine behavior. So these are the simplest clues to make out or suspect autism in a child. Next is, now the problem can start with the diagnosis itself. Most of the parents don't like the word autism. We make a diagnosis of autism and tell to the parent that this child is having autism or autistic spectrum disorder. Most of them do not like that. The other terminologies can be used are pervasive developmental disorder, or high functioning autism, or Asperger's syndrome, or clinical childhood disintegrative disorder, or a Kanner syndrome. I like the word Kanner syndrome. I'll tell you why. So this is the reason behind is that Kanner was the original manuscript author of autism. He is the pioneer. Almost a century ago in 1938, he made a very beautiful observation of a small group of children, about 11 children, who had this sort of a peculiar behavior. And he was not able to come to a conclusion at that time because autism was not known. And he gave a detailed description of those child behavior, which we today call it as autism. Even after 90 years of almost a century now, with the advancement of molecular biology and various technology, neuroimaging, nothing much is going to be added to this original description. He says that to assess or evaluate an intellectual quantity is easy. Like, for example, you can assess a developmental or a language defect or a learning disability or what is called as intellectual deficit. But to assess an emotional quality is very difficult. That is what he has written here, emotional quality. So these children are emotionally backward. So the deficit, which the core deficit in autism is that there is a deficit in social relatedness to oneself and surroundings. These children are happy left alone, self-satisfied, never cries to go out, not bothered about fathers coming home or when somebody else leaves the house. They are not bothered, acts as though the people were not there in the house at all. They simply absorbed in silent wisdom. These children tend to be, they want to be disregarded and ignored. There is a strong tendency or an all-powerful need to be left undisturbed. They don't want to be disturbed. So what are the situations which can create problems? That is the dislike for intrusions. Any disturbance, their children don't like. The first problem starts with the food. When the mother is trying to feed, it is actually an intrusion. To us, it looks like a nutrition. A child who's trying, the mother who's trying to give a proper nutrition to the child. But from the child's point of view, it is nothing but an intrusion. I'll show an interesting video also. The child, this can manifest as a food refusal or vomiting or tendency to like only a particular type of food with a particular type of a texture. So the main problem is a food refusal is an early clinical clue for a child who's developing autism. The second situation is that moving objects, like for example, a cycle or a swing, a problem can arise in a park. A child is brought to a park, a common public park, and they see some other children who is enjoying a swing. This acts as a sensory intrusion for the child and results in a lot of anxiety and behavior problem. And the third thing is a noise. Mechanical toys are not liked by these sort of children. Wind or a vacuum cleaner. These acts as a sensory intrusion, and the child behaves in a weird way, in the form of increased anxiety or even a temper tantrum. From the doctor's point of view, or even from the parents' point of view, we are at loss to understand why this child is behaving in such a way. But when you look at it from the child's angle, it is nothing but an intrusion into the peacefulness of the child. The child wants to be left undisturbed. And these are the situations which are disturbing the child. And the child behaves and throws a temper tantrum, which we are not able to understand. So I will show you this video. You see that of a child. Then, as a rule, we should rule out intellectual deficit or a developmental mental retardation in a child with autism. A child with mental retardation or intellectual deficit can have autistic features, but that doesn't result in a diagnosis of autism. And we have to look for red flags or mimickers which can mislead to us to a wrong diagnosis of autism. So what are those mimickers are? As I said, this is intellectual disability or mental retardation. Sensory impairment, particularly deafness or visual deficit, can result in anxiety and difficulty in understanding the situation and a behavior which is similar to autism. Reactive attachment disorder or a neurosis and psychiatric conditions like obsessive compulsive disorder or generalized anxiety disorders can mimic autism. Stereotypic movement disorders, repetitive tics or movement disorders can mimic that. And attention deficit hyperactivity. These are the things should be ruled out before giving a diagnosis of autism. And inborn errors of metabolism can also mimic or result in autistic features, particularly phenylketonuria, hyperhomocystinemia, acute intermittent porphyria, and mitochondrial. So what are the clinical clues so that we don't make a wrong diagnosis? That is, in other words, red flags in the diagnosis of autism. One is the staring spells. These can give a clue to the underlying seizures or epilepsy. Ash leaf macules in the skin, which can give a clue for tuberous sclerosis. Facial dysmorphism. Injuries, sometimes battered children or battered babies because of household injuries can mimic autistic behavior. And a sibling with autism that indicate the child would have or consanguineous parents. That's a family history of autism running in the family that gives a diagnosis or a clue that it's an autosomal recessive disorder from an inborn error of metabolism. And hypothyroidism can also, clinical external features of hypothyroidism, one should look and rule out these conditions before branding it or thinking of autistic features. The metabolic conditions, as I told you, are PKU, hyperhomocystinemia, cerebral folate deficiency, pyridoxine dependencies, porphyrias, and mitochondrial disorders. Interestingly, some of these inborn errors of metabolism are also treatable. It is not that they are all untreatable. If you can make a diagnosis of phenylketonuria, one can restrict phenylketonuria in the phenylketones in the diet and cause improvement. Similarly, for porphyrias are treatable. Pyridoxine is very easily treatable. A simple pyridoxine tablet can solve the entire behavior of the child. So these are all the treatable, easily treatable autistic syndromes. So what are the early clues of autism? One is the social relatedness. An observant mother can tell you that the child doesn't make postural adjustments before the child was being picked up. So this is an important social milestone which the child derives by around 1 month as early in the neonate period itself. The child does not make any postural adjustment before being picked up. No adjustment or just allows the child to be manipulated like a sack. However, the child doesn't mean that the child is weak or having a neurological problem or hypotonia. The child can even walk, but the child does not cooperate to be picked up or lifted up by the parent. Looking at a part of the intruder, but not at the face. The face recognition or the eye contact will be totally absent. Angry and afraid of the needle rather than the person. For example, when a child is taken for an immunization, routine immunization, the child will look at the needle and get angry at the needle rather than at the person who is doing the vaccination. The second thing is, another important thing is the object related. The first one is the social relatedness, which is totally lacking. And the object relatedness, which is phenomenally good. You find that this developmental milestone is advanced. You find that they are able to manipulate objects and get control over objects, which we normally use in day-to-day life with much more manual dexterity, which is required for that child's age. They can exercise power and control with simple objects and gain an ecstatic joy in that. I'll show you a video in that. You see that this child, see how easily and the child having a repetition of heard word combination with the same intonation. He just repeats what is told to him, which we call as echolalia. and the delay in understanding certain concepts like the word yes. He may not be able to understand what this word yes means. And words are used as an inflexible and can't use beyond the first situation. And the child has its own peculiar grammar with the literal meanings. For example, a child has used the word yes for can I lift you up? The child says yes, and the mother lifts the child. And the next time the mother asks, do you want coffee or milk? The child says yes. Now he thinks that he is going to lift the child again rather than giving him some food. So the initial meaning is stuck up. The words are inflexible and it's used beyond the first situation. This is very typical of autistic language. So the autistic language acquisition is not used for useful communication, other diverted for using a self-sufficient, semantic, conversationally useless memory exercise. So this, we can give examples like that. Say, for example, if a child knows a list of presidents of a particular country or calendar dates or botanical names or rhymes without singing it in a proper way to a particular purpose, he just remembers all the rote memory, all the names. For example, Bala sir had referred a case, a young child was able to give me the calendar dates. Whenever we say the year and the month, he could tell the day which is falling on. But that is not conversationally useful. The fourth clue is that the child has a peculiar form of a play which is involved in solitary play. He does not engage in a group play. When he is forced to enter into a group play, he moves like a stranger, strolls to the periphery, removes himself from the game, and tends to remain alone. He plays repetitive solitary play. He plays is self-sufficient. So how to examine? I say all these are the clinical clues, but when you summarize these clinical findings, it can be divided into three broad categories. One is a deficit, second is a deviation, and third is the associated finding in the clinical examination. Now the deficit is what is expected for the child's development he is not doing. The deviation, he does that in a peculiar way, and there are some associated findings. So I just mentioned some important thing. The deficit, there is, as I said, there is no social and emotional reciprocation. There is no eye contact. The language is delayed, and the play is solitary, and play is rather delayed. And particularly the pretend play, I'll elaborate this later on. And the deviation, you know that the child will have a repetitive form of a weird behavior or weird repetitive routine, ritualistic, rigid interest. So these, remember these 4 R's, they require sameness. Any change in the routine, the children may not like, very fixed rules. So these are the deviations in behavior. And the associated features are they'll have sensory aspects like a dislike to a particular sound or a texture or a light or a particular food. But they will have well-developed behavior in certain higher functions like puzzles, art, or music. And they can have some odd gait or a dyspraxia, or sometimes even ADHD can be associated with autism. So since we are dealing with this sort of a social problem, the social development, I thought we'll just give you an overview of social developmental milestone in a normal child. So we have a social development starting in the neonate itself. A newborn or born within the first 30 days has a visual preference for human face. That's very interesting, a newborn baby. By 1 month, his social smile begins to start. By 3 months, it is totally established. And it can be sustained when the child expresses displeasure if the social contact is broken. For example, the mother looks at the baby, the child enjoys the eye contact. And when somebody calls, the mother takes the eyes away from the child doesn't like. The child shows some sort of a displeasure to that. So this milestone is by 4 months. That means there is a clinginess or a want for a sustained eye contact. And these are all the other milestones. By 10 months, the child starts playing peekaboo. 1 year, the child has a postural adjustment, which is fully formed by around 1 year when the child helps for dressing up. And by 18 months, the child points and hugs parents. He points for objects. He points out and tells that I want this and I want that. By 18 months, the child expresses his love by kissing the parents. And by 2.5 months, pretend play. This is a very, very major milestone, which I'll explain now. And by 4 years, plays in parallel. And by 5 years, there is a group play or an interactive play in the form of a teamwork. So these are the sequential evolution of a social milestones in a child. So you find that the gestural development, you see this child is pointing out. There are two types of pointing. One is called proto-imperative pointing, which means the child requests for a particular object. Give me that, give me this. And a proto-declarative object, proto-declarative gesture indicates if you ask, then he can point out this object is in this position. He can point out an object that is called proto-declarative gesture. Both these pointing are an important milestone by 18 months. After 1.5 years, the child will be able to do both this sort of a pointing, which is grossly delayed in autistic children. You can see this child has this form of a play wherein the child is playing with a real car, whereas this child is playing with a pretending play. This is called a pretend play. The child uses this aeroplane as a steering and this child as a passenger. So this pretending play is a more sophisticated development rather than the actual play. This child is playing with the actual car. This child is able to use this toy as a car, which is actually an aeroplane as a car. These are all different types of a pretend play, which we normally see in our household. The child as though they are cooking. These are all sophisticated forms of a normal development of a play. And this child is pretending to be a doctor and the patient. You see the eye contact, which is well established, and behavior, the joy that is expressed. These are all forms of a pretending as though there's a teacher and they're playing with a toy. So this is all very important social milestones, which is not seen in autistic kids. Now, next we come to the emotional developmental milestones. So by even cry can be used as a tool for communication. The communication need of the child is communicated by means of a crying. By 2 to 6 months, the child can understand facial expressions and even mimic the facial expressions of primary emotions. By 12 months, the child has a stranger anxiety. By 2 to 5 years, the child has, whenever there is a child is angry, they can throw a temper tantrum, a possessiveness or a anger or a jealousy. Now, by 3 years, the child can understand the person's mental state by looking into the person's eyes. See, for example, it is not that the person is looking to the left side. You can make out the person is angry by looking at the face. So that milestone is come by 3 years. And most importantly, by the next year, by 4 years, children can recognize that others have their own thoughts. Now, this concept is called theory of mind, otherwise called TOM. So theory of mind, I'll be discussing it in detail because that is the fundamental problem in autistic kids. It's a bit slow. Okay. Now, what are the causes? As I told in the beginning of the talk, that the etiology is not straightforward. We don't have a particular cause or an etiology towards autism. They have researched on various conditions or various causes for, like, for example, genetics. There is no single gene that can cause autism. There is no particular environment which can cause autism. They have particular food which is causing autism. But what almost like a good association, as I thought I'll share with you, is that the role of parental occupation in autistic spectrum disorder. It's a very good manuscript presented recently. They say that children born to highly intelligent families with less direct contact with people, like, for example, musicians, chemists, botanists, plant pathologists, writers, historians, arts, or scientists, who do not meet the public in day-to-day life, they have a higher tendency to have autism. And the second thing is, does the autistic child have a theory of mind? As I told you, the theory of mind is nothing but the ability to conceive or guess other people's state of mind with all its emotions, feelings, wants, or beliefs. It is a second-order representation. It usually appears in the second year of life, and it manifests as a pretend play, as I told you earlier. And this happens irrespective of the intelligence of the child. And different people have different beliefs about a situation, the ability to understand what is happening in other people's mind. And it is a fundamental social skill which is absent in children with autism. It is something like standing in other person's shoes or reading some other's mind, looking at a problem from the other person's perspective. So, for example, there is an important study, an interesting study. I'll show you this a simple study which has been done to study the theory of mind in a child. You find this is the experimenter and this is the case. These are two children here. Who, the first child, Annie is one child and Sally is the other child. Now, this child, Sally, keeps a marble inside a basket and goes out of the room. And when this child has gone out, the child who is inside the room shifts this marble into the basket, from the basket into the box. And when the child comes back again, the question which is asked is, where will he look for the marble? The child simply says that the child will look into the place where it is actually is, that is the place or the new place. But the person, that is the control person, the case person says the child will look into the place where it is actually is. But the fact is the child will look into the place where it has seen it earlier. He is not able to understand the point or the mental makeup of the person who is actually gone out of the room. He is stuck with the reality. He says that the Sally looks into the box where it is actually is. But the Sally doesn't understand this particular situation that the marble has been switched in the absence of the child. So this is called the theory of mind. And the theory of mind is not being able to be employed properly by children with autism. There is inability to represent the mental states of the other person. So they are unable to impute beliefs to others and thus are a grave disadvantage having to predict the behavior of others. They are not able to understand what is in the mental makeup of the other person. And the second concept is that in autism, there is an underconnectivity between the reward circuitry and the language process. So you look here that whenever we have a social activity going on, like social attention or social cognition or a language analysis, this is transferred to a reward circuit. That is a ventral tegmental area of the brainstem and orbitofrontal area. This gives us an inherent reward or a happiness. When there is no communication between the language or the social activity to the reward circuits, we find that there is no inherent joy in any social activity. So these children do not get any pleasure in social activity or social engagement. So this concept is called a social motivation defect. There is actually a social orienting, a social seeking, or a social liking and social maintaining in normal individuals. This is a normal milestone. Pro-sociability is intrinsically rewarding. The classical example is taking a selfie and posting. And all of us are doing this day by day. By taking a selfie, requesting for likes in videos. And these are all indications that we are all socially oriented and socially seeking. And social maintaining is a basic homeostatic mechanism. We want to be socially liked or accepted by the other person.